Hello, everybody. My name is Jean-Pascal Machiels. I'm professor at UC Louvain in Brussels. I'm also a medical oncologist and the medical director of the Clinique Universitaire Saint-Luc in Belgium. My main interest is head and neck cancer, as well as translational research and early clinical trials. The approval are a little different between EMA and FDA. In Europe, with EMA, we can use pembrolizumab in the first line, so the first recurrent and metastatic line. And pembrolizumab can be used in monotherapy or with chemotherapy, platinum 5-FU. And to have access to immunotherapy in this setting, the tumor must express a PD-L1 with a CPS score of 1 or higher. For the FDA, you can use pembrolizumab in combination with platinum 5-FU, also for the first-line treatment of a patient with metastatic or recurrent disease, and this independently of the PD-L1 status. If you wish to use in US pembrolizumab monotherapy, like in Europe, the tumor needs to express PD-L1. If we look now at the guidelines, how are we going to manage this group of patients? And I think that we can divide the patient into 3 groups. For example, we have patients in the first line, and this patient did not receive platinum therapy during the last 6 months, and this tumor expressed PD-L1. And in this case, you can use pembrolizumab monotherapy or pembrolizumab plus platinum 5-FU according to the ESMO guidelines. And for this group of patients, clearly, they need to express a PD-L1 like the recommendation made by EMA. If we have no PD-L1 on the tumor, you may use, according to the FDA approval, you may use platinum 5-FU pembrolizumab. That's an option. But we like, if we don't have expression of PD-L1, in Europe, we don't have access. And so for this group of patients, the standard of care will be platinum 5-FU and cetuximab. A third case is when you have no PD-L1 assessment. And I strongly believe indeed that we don't need, that should not happen anymore in this group of patients, because we should assess PD-L1 in all the patients. But if it is the case, you can use a pembrolizumab plus platinum 5-FU. If we look at the NCCN guideline and the Society for Immunotherapy of Cancer guideline, this is quite similar. I would say that there is a little difference for the Society of Immunotherapy because they will also add in their guidelines recommendation the combination of carboplatin and paclitaxel plus pembrolizumab based on a large phase 2 trial with more than 100 patients that demonstrate activity in this group of patients. Indeed, in US, as a chemotherapy backbone, generally they prefer to use carboplatin and paclitaxel instead of platinum and 5-FU. And here we have 2 possibilities. For EMA, we can use pembrolizumab after platinum therapy, and this is restricted to the patient that have a tumor that express a high level of PD-L1 with a TPS score of 50 or higher. The other possibility is to use nivolumab, and this is you don't have restriction according to the PD-L1 status. And for the FDA, you can use either pembrolizumab or nivolumab. So if you look at the ESMO guidelines, when are you going to use nivolumab or pembrolizumab in second line? So it's mostly after platinum therapy if the patient progress after platinum therapy. The guidelines are extremely similar if we look at the NCCN guidelines and the Society of Immunotherapy for Cancer. In the KEYNOTE-048 trial that compare pembrolizumab monotherapy versus pembrolizumab chemotherapy versus cetuximab chemotherapy, the 5 years overall survival rate was with pembrolizumab monotherapy 20% in a patient with a high expression of PD-L1, so meaning CPS 20 or higher, and 14.4% in the total population. If we look at the group of pembrolizumab plus chemotherapy for patients with a high expression of PD-L1, CPS 20 or higher, the 5-year overall survival rate is 24%, and it's 16% in the total population independently of the CPS. If we compare this to the extreme regimen, you can see that the 5-year overall survival is 7% or 5% depending on the group. If we look at the long-term outcome from the CheckMate 141 trial, this trial was designed for patients that progress after platinum therapy. And we have a subgroup of patients that were treated with platinum therapy given during the curative intent treatment. And so technically, this group of patients are in the first line of recurrent metastatic setting, but this group of patients were not included in the KEYNOTE-048 trial, because in the KEYNOTE-048 trial, you should not progress within 6 months after platinum therapy. And importantly, they show that in this setting, nivolumab maintained the overall survival benefit versus chemotherapy at 2 years, with a median overall survival of 7.7 months in nivolumab compared to 3.3 months in the experimental arm. The KEYNOTE-B10 trial is a phase 2 trial with 101 patients that combine pembrolizumab plus carboplatin and paclitaxel. And the reason to do that is because 5-FU is not frequently used in US for toxicity reasons. And also that sometimes we have patients that cannot tolerate 5-FU, for example, patients with TPD dysfunction. And in this setting, they show that the objective response rate is 49%. And so we have still a good activity of carboplatin, paclitaxel, and pembrolizumab in this group of patients. So it's certainly an alternative treatment that we can use in this setting. In the second line, we have also a long-term overall survival, and we can see that higher is the PD-L1 of the tumor, better will be the outcome when we will be treated with pembrolizumab, but that we have also in this group of patients in the second line a long-term benefit of immunotherapy. We have to take into account several parameters. We have to take into account the comorbidities of the patient. Is the patient able to support or to deal with chemotherapy, for example? We have also to see what is the status of the patient. Is it a frail patient or not? Because if we have a high CPS score, we may imagine to spare chemotherapy to this patient and to give pembrolizumab in monotherapy. And also take into account the tumor characteristic. Is the tumor growing very fast? Do we need a rapid tumor shrinkage because the tumor gave high symptom or the patient is at risk of death rapidly? And also the level of the PD-L1 score is important. Patient with a higher score has better chance of response. So practically what we are doing, when we have patients that we need to have a rapid tumor shrinkage, patient highly symptomatic, we give chemotherapy plus pembrolizumab, for example. And in patient with slow progressive disease, high PD-L1 score, not very symptomatic, we choose generally pembrolizumab monotherapy. Hello, everybody. My name is Jean-Pascal Machiels. I'm professor at UC Louvain in Brussels. I'm also a medical oncologist and the medical director of the Clinique Universitaire Saint-Luc in Belgium. My main interest is head and neck cancer, as well as translational research and early clinical trials. Let's first look at the KEYNOTE-048 trial that compared pembrolizumab monotherapy versus pembrolizumab plus chemotherapy versus cetuximab plus chemotherapy. The first key message is that the incidence of any grade is much lower in pembrolizumab monotherapy. For example, in pembrolizumab monotherapy, any grade of toxicity were observed in 58% compared to more than 96% in the chemotherapy arms. If we look at the grade 3 and grade 4 toxicity, is only 17% in pembrolizumab monotherapy compared to 72% in pembrolizumab plus chemotherapy and 69% in cetuximab plus chemotherapy. So when we have pembrolizumab monotherapy, we don't have the toxicity of chemotherapy, obviously, and the most frequent toxicity as fatigue and hypothyroidism, but a very low rate of this toxicity at the level of grade 3 or grade 4. If we look at the other trial that investigate nivolumab, we have similar results. What is also key for this group of patients, even if we have good tolerance of the treatment, we have to be aware that sometimes we'll have severe autoimmune toxicity. And among this severe autoimmune toxicity, we have pneumonitis, and this pneumonitis can occur with pembrolizumab in around 6% of the patient, but it can be grade 3 or grade 4 in 2% of the patient. And we need to be aware of this because we need to inform the patient that if they experience, for example, dyspnea, they have to tell us and they have to come to the hospital. We can have also other grade 3 and grade 4 toxicity, like liver toxicity or neurological toxicity or cardiac toxicity. But again, the grade 3 and grade 4 are quite rare, but we need to inform our patient about that. The first patient that we can discuss is patients that are older, or what we call the frail patient in first line, for example. So in first line, we have different trials, and let's look at this trial, how they can inform us about the tolerance of this treatment and the activity of this treatment in this group of patients. For example, the KEYNOTE-B10 trial that investigates pembrolizumab plus carboplatin and paclitaxel, this group of patients had some comorbidities, and they have a 46% that were aged over 65 years. But the objective response rate was similar between the patient that had lower or higher than 65 years. Also, with this treatment, some patients experience toxicity, the toxicity of chemotherapy, but the rate of discontinuation of pembrolizumab was only 10%. If we look at the KEYNOTE-048 trial with pembrolizumab monotherapy versus pembrolizumab plus chemotherapy versus cetuximab chemotherapy, also we have the similar activity in patients over 65 years or patients they are younger, less than 65 years. Interestingly, a small phase 2 trial with 40 patients, the Frail Immune GORTEX study, investigate durvalumab plus paclitaxel and carboplatin in patients not eligible for cisplatin. And this patient had an ACOG performance status of 2. And in this group of patients, they observed that the treatment was very active with a median overall survival of 12.4 months. Similarly, this has been also investigated in the second line, so after platinum therapy. There are different trials, like the TOP-NIVO study, and all these trials demonstrate that this treatment can be tolerated by this group of patients and also has some activity. Let's now look at patients with immunosuppression. For example, a difficult population and quite a rare population is patients that have solid organ transplant. And for this group of patients, it's obvious that if you give anti-PD-1, you may induce allograft rejection. According to the different trials, the overall allograft rejection is around 41%. But you have still activity of anti-PD-1 in this setting, with objective response rate between 20 and 50%, depending on the group. If we look at this group of patients, we need to know about what kind of allograft they have. For example, if they have a kidney transplant, but we know that for this group of patients, if we have allograft rejection, we can still put the patient with dialysis or hemodialysis. But for example, with liver transplantation or cardiac transplantation, the risk is higher. So in our practice, we can discuss with patients with a kidney transplant to give this treatment. If they wish, that's a discussion with the patient. We can also give this treatment with patients with autoimmune disease if this disease is controlled, although we have a risk of increased autoimmune toxicity. And so we need also to discuss with the patient. We have to need to be free of a steroid treatment, but this treatment can be active in this group of patients, although we may increase the risk of autoimmune adverse event. Regarding infection disease, and for example, HIV infection, we have trials that investigate pembrolizumab in this group of patients. And in one study with 30 patients, they select patients with CD4 count more than 100 cells per microliter. And in this group of patients, pembrolizumab has an acceptable safety profile, also with some activity. And maybe we observe a Kaposi-induced associated B-cell lymphoproliferation that were a little increased. Also, with hepatitis B or hepatitis C, globally, you can give this treatment to this group of patients. You have clearly to monitor the level of the virus if the disease, if the hepatitis is still active, but you don't have an increase in the autoimmune-induced liver toxicity in this group of patients. Clearly, you need to do some prior assessment in this group of patients. First, you need to do an interrogation to see if there is no autoimmune problem. You need to examine your patient correctly, and you need, in our opinion, to do some blood test that will include the TSH, the T4, classical blood testing. You need also to do neurological exam, check for hepatitis, and also look at the creatinine kinase enzyme. Depending on the profile of the patient, you can also do EKG, look at the troponin, sometimes pulmonary function. It can be helpful if these patients are going to develop such a toxicity. And in the routine, we generally do also cortisol and as ACTH for this group of patients. During the treatment, it's also extremely important to monitor the toxicity. Again, we need a careful exam of the patient at each cycle before infusion. We clearly also need to look at the liver enzyme very regularly, and certainly each time before pembrolizumab or nivolumab injection, but we need to look also at creatinine and all the other organ function. When we have a toxicity, it's important to grade the toxicity. If we have grade 1 toxicity, we can just monitor closely the patient, and we don't need generally steroids. For grade 2, it can be already a little different. You need to stop the immune checkpoint. And you need to follow carefully the patient. And if the symptoms are not improving, quite rapidly, 2 or 3 days after, you should try to start steroids. Generally, we start with 0.5 milligram per kilogram steroid to control. So what is important is that in the contrast to chemotherapy, already a grade 2 toxicity, you need to start steroid. For grade 4 and grade 3 toxicity, you need higher dose of steroids, and sometimes we hospitalize the patient to monitor the toxicity. This is an important question. You have to be aware that immunotherapy is going to induce inflammation, and sometimes this, due to the localization of the disease, can have some consequences. For example, if you have edema, this can compromise the airway, and especially if we have the tumor that is already have an impact on the airway clearance. So something that we need to monitor. We need also to monitor that the response to this patient, because sometimes the tumor engages the carotid artery, and in case of huge response, we may have a carotid artery rupture. So head and neck cancer is a little different disease than other disease, because this inflammation can have some impact due to the toxicity of some of the treatment. So yes, it's really important that when you see the patient for the first time, first you say that the toxicity is less than with chemotherapy, but you need to raise the attention that sometimes in 4 to 5% of the patient, you will have severe autoimmune toxicity. You need to describe this toxicity for the patient. For example, if you have dyspnea, please call us and come to the hospital. And everything that is going to be different than before, you need to make your doctor aware of, because this may have an impact and related to autoimmune toxicity. Hello, everybody. My name is Jean-Pascal Machiels. I'm professor at UC Louvain in Brussels. I'm also a medical oncologist and the medical director of the Clinique Universitaire Saint-Luc in Belgium. My main interest is head and neck cancer, as well as translational research and early clinical trials. First of all, you have to know that in the curative setting, when you have a locally advanced disease, the relapse rate within 1 year is 33%. And less than 50% of the patient will be alive after 5 years. And we have also a high rate of short-term morbidity related to chemotherapy. And also the surgical approaches that can lead also to significant cosmetic and functional morbidity. First of all, even if the disease is resectable, it doesn't mean that you are going to operate your patient. Something these patients are treated with chemoradiation, because the functional outcome will be better with chemoradiation compared to surgery. And we have a different trial that try to combine immune checkpoint with chemoradiation. The Keynote 412 trial and the Javelin 100 trial. The Keynote 412 trial show a favorable trend to improvement EFS with pembrolizumab versus placebo, but this is not statistically significant. So yes, it seems that in patients with a high PD-L1 expression of tumor, in this setting, pembrolizumab may improve the outcome, but the trial was negative, and so it's not approved in this setting. The Javelin 100 trial, it was a similar trial with avelumab, but this was a completely negative trial, and this trial did not meet the primary endpoint. In resectable locally advanced head and neck cancer, but in patients select for surgery, we have now two trials. The Keynote 689 trial. This trial gave before surgery 2 cycles of pembrolizumab, and after with radiation or chemoradiation, pembrolizumab was continued and was also given as an adjuvant treatment. This trial met its primary endpoint. The primary endpoint was the event-free survival, and the median event-free survival in the total population was 51 months in the experimental arm, so in the patient that received pembrolizumab, compared to 30 months in the control arm. In patients with CPS 10 or higher, the median event-free survival was 59 months in the experimental arm. So this trial was positive, and in my opinion, is a new standard of care. We have also another trial that was performed in a little different setting. Patients were operated up front, and patients select for chemoradiation after surgery, so patients with a high risk of relapse, so patients with positive margin or extranodal lymph node extension. This patient was selected for chemoradiation, and in the trial they compared chemoradiation plus nivolumab versus a chemoradiation alone. This trial also met its primary endpoint with a 3-year disease-free survival of 63% in the nivolumab arm and 52% in the control arm. So clearly, when we operate the patient or when we plan to operate the patient, we have now 2 trials that demonstrate that anti-PD-1 therapy can improve the outcome. So I think it's going to change the standard of care. And as shown here, it has been approved by the FDA in June 2025. So pembrolizumab has been approved as a neoadjuvant treatment for patients that are going to be operated with squamous cell carcinoma of the head and neck. The condition is that the tumor expresses a PD-L1 with a score measured by CPS of 1 or higher. And in this group of patients, like in the Keynote 689 trial, we are going to continue pembrolizumab during chemoradiation or radiation and as an adjuvant during 1 year. So this is completely going to change the practice that we have with this patient. So when those patients are now presented in the multidisciplinary board, the surgeon is informing us that it's planning to operate the patient, and we need to organize the team to see the patient, to see if he's fit for anti-PD-1 treatment, and to make the treatment plan according to the 689 trial. Today, when we have a patient that is going to be operated, we need to consider anti-PD-1 treatment for this group of patients. If we have locally advanced disease up front, we need to discuss if these patients are eligible for neoadjuvant pembrolizumab. If yes, we need to discuss with the patient and probably give the drug to the patient and continue the drug during postoperative chemoradiation and as adjuvant treatment. If the patients are operated and that we have a patient with a high-risk disease, so a patient who is eligible for postoperative chemoradiation, we should also consider to combine chemoradiation with nivolumab. For the future, we may have some patients that will receive anti-PD-1 treatment in the context of curative intent treatment, so this group of patients that we just discussed. And if this patient relapse, it will be important to investigate if we need to re-challenge this patient with anti-PD-1 treatment or not. I personally think that it will be probably less active, but maybe if we have a long interval, several months between the end of anti-PD-1 and the relapse, that some of these patients will respond again to anti-PD-1 treatment. Yes, the role of the multidisciplinary team in patient selection is crucial. So we need now to have a discussion with the surgeon, with the medical oncologist, with the radiation oncologist to build the plan of the treatment. We need clearly to assess the PD-L1 upfront in this group of patients. And we have two possibilities. If we know that the patient is selected for surgery, we need to assess to give the treatment, the pembrolizumab as a neoadjuvant treatment. But you may also have some patients that you think that the patients are low risk. The patient, they go for surgery. And after surgery, you see that the patient have a high risk of relapse. And in this group of patients, due to the GORTEC trial, we know that adding nivolumab to chemotherapy, to post-operative chemoradiation will improve the outcome. And we should try to add an anti-PD-1 in this setting.